Hello, everyone. I'm Barbara Ham Lee. Obesity, heart disease, high blood pressure, diabetes, breast cancer, asthma, diseases that can affect us all, but have a significantly disproportionate effect on African Americans as well as other minorities. We know that education, prevention, and an end to ethnic and racial disparities can make a difference. That's why the Centers for Disease Control and Prevention have developed the program called REACH, Racial and Ethnic Approaches to Community Health. There's a REACH program here in Norfolk, and we'll tell you all about it on this edition of Another View on Health with my co-host, Dr. Keith Newby, right after this news from NPR.
Discussing today's topics from an African American perspective, this is Another View.
And good afternoon, everyone, and welcome to Another View. I'm Barbara Ham Lee. Thanks so much for joining us this afternoon. It's called REACH, and it stands for Racial and Ethnic Approaches to Community Health. It's a nationwide initiative by the Centers for Disease Control and Prevention to eliminate racial and ethnic disparities in health. REACH does what its name implies. Participants reach into affected groups to find people on the ground to help determine programs and strategies that improve the health and well-being of that community. There is a REACH program here in the city of Norfolk, and here to tell us about it is Joyce Jones Guinyard, REACH Project Manager and Community Liaison with the UCLA Fielding School of Public Health. Dr. Guinyard, thanks for joining us.
You're welcome.
Thank you for being here.
For having me.
Terrance Afer-Anderson, who is a health educator with the Norfolk Department of Public Health. Hi, Terrance. How you doing?
Nice seeing you.
Good. And Amy Paulson, Director of CINCH with EVMS. Hi, Amy. Hi. So glad to have you here. And of course, I'm joined by my co-host for Another View on Health, Cardiologist Dr. Keith Newby. Hi, Keith. How are you?
All right. Yourself?
Good. I'm doing great.
Good.
So, Joyce, I want to start with you. What exactly is REACH, and what are you all doing in LA?
Well, REACH is a program that is designed to effectively engage communities in both identifying barriers to health and then developing programs that will help to eliminate some of those health those health barriers and ultimately health disparities. Mm-hmm. In Los Angeles at UCLA, we are one of 6 grantees who was provided funds to actually contact or work with groups across the country. We know that individuals in or groups within communities are the best people to do this work. Mm-hmm. And so we are helping them both. We're providing resources, of course, financial resources, but more importantly, we're trying to provide technical assistance mm-hmm. and trainings and other resources that they need to work most effectively with mm-hmm. their communities.
And there are different minority groups that are affected. African Americans, yeah. Obviously, Asians, Native Americans, etc. So are there different issues depending upon the population?
There are different issues, but REACH, in this iteration, at least the work that we're doing in our program we call Healthy by Default, we're helping groups both within the African American, Asian, Pacific Islander, and Latino communities to do this work in ways that they feel are most important and most beneficial. Mm-hmm.
So it's not someone from the outside coming in, but asking actually the community that is affected to make exactly. Some of those decisions.
That community is the best. They are the best people to do that work. And all we want to do is make sure they have the appropriate resources to do the work.
Okay. Amy, so we have REACH here in Norfolk, and it's a part of Healthy Norfolk. Why the city of Norfolk, and what made you all decide to go for that type of program?
Sure. Well, we've been working actually with Healthy Norfolk since its inception. It was actually an outgrowth of our Healthy Portsmouth initiative that also had CDC funding. And we had worked with them for a while as a member and as a catalyst to move that forward. And we'd had some things we wanted to do in our action plan, like implement a complete streets policy here in Norfolk. And we could talk about what that means a little bit later, mm-hmm. and some things like that. And so when we had the opportunity to apply for the REACH funding, it was really a perfect fit for what we were trying to accomplish with Healthy Norfolk and had envisioned, but didn't have the resources to do. Mm-hmm. And so we were able to get together with some of those partners and apply for the funding. Norfolk was eligible because we didn't have any prior CDC funding through any of the other similar grant lines like Achieve or Communities Putting Prevention to Work. Mm-hmm. And so we applied, said what we wanted to do, and I guess people at UCLA and CDC decided that it was a good idea what we were trying to accomplish here in Norfolk.
Now, tell people what Healthy Norfolk is all about, just in case they're not aware.
Sure. Healthy Norfolk is the city's health initiative. It's a coalition approach, so there's a group of partners that are all working together to improve physical activity, nutrition, and tobacco use here in Norfolk. And those are really the three big things that contribute to the worst health outcomes that we see in our community, to chronic disease, death, and disability, both here in Norfolk and in many of our other cities. So these are, all related to obesity and diabetes and hypertension and stroke and all these other things that we don't like to think about but are really impactful here, particularly in Norfolk. And when we look at our minority populations, in particular our African American population here in Norfolk, which is a large proportion of our overall population here, we start to see the impacts from poor nutrition and lack of physical activity and tobacco use. Our REACH grant only focuses on physical activity and nutrition, although we do have other partners like Terrance here and also CINCH that are continuing to work on tobacco issues outside of our REACH grant. So it's a really great opportunity for us.
So part of this grant, Terrance, is all about eliminating health disparities. So you work for the health department.
Yes.
Talk to us a little bit about what those disparities are. When someone says a health disparity, what does that mean exactly?
Well, it's a disproportionate incidence of encounters with a variety of health situations. Prime case in point, African American men in Hampton Roads are believed to have the highest incidence of prostate cancer deaths nationwide. And when you look at the incidence of smoking and the consequences of smoking, again, African American men in Hampton Roads have extraordinarily disproportionate rates. If you look at lung and bronchus cancer, the incidence of lung and bronchus cancer amongst African American men is pretty extraordinary. It's 98.1 per 100,000 men deal with lung and bronchial cancer. But when you look at the incidence of mortality that's associated with that number is 78.9. So it's some extraordinary incidences that we're dealing with in terms of the disparities.
And does some of those disparities have to do with access to health care?
Absolutely.
To nutrition, to education?
Yeah. I worked with brought in an intern from EVMS, an MPH student last year to help us define food deserts in the area, and we found a number of them. And the research that we did just gave us some pretty startling numbers, particularly how the food deserts, living in a food desert,
and remind people what a food desert is.
A food desert is an area, a geographic location within a city where there's low or limited access to nutritious and healthy foods. And when we did a BMI study a couple of years ago, back in 2011, and that BMI study revealed that 44.7% of Norfolk public school students are obese.
Wow.
Yeah.
That's almost half.
Yeah.
Of all students. My goodness. So, Dr. Newby, programs like this, they make a difference from your perspective as a cardiologist in terms of the education and prevention side. Does that matter?
Yeah, I think it definitely matters. When you're looking at why these things happen, the majority of the time it is lack of education. I mean, I think people... think about the lifestyles that most people have. They develop those lifestyles over generations and generations, and trying to break that lifestyle is difficult. I mean, you think about, why do African Americans have a higher incidence of coronary disease or heart disease itself? When you look at the diets are going to be high in fat. There's going to be a lot of, the types of oils that are used. I mean, I remember the Crisco from the old days, so like ice cream coming out, you scoop it out. But, you think about that, but it's cheap. And what you find is that a lot of families who are living on fixed incomes, they get what they can because they don't have the resources necessary to get, the more nutritious foods. I mean, unfortunately, so, can people grow their own foods where they live in sections where it's difficult to do that? Do they have access to those types of foods? A lot of them don't. And so they live on what they have. And you're trying to teach people, say, okay, you need to eat better, you need to do it this way. And they look in and say, okay, yeah, but I can get this for $1. I got to spend $20 to get this stuff. And trying to say, okay, how can you find that mixture? How can you find that way of being able to say, okay, it's like I have some patients that grow their own food. They bought planters, and they grow their own tomatoes, their own cucumbers, whatever the case may be, and they have that separate outside. They may live in a section where there's no ground, but they find ways of making it work for them.
Community gardens, as an example.
So a lot of those, you find the educational piece plays such a big factor because they are able to see the benefits if they do it this way versus that way. And that's where, I agree with that 100%.
So, Dr. Guinyard, I want to ask you, what are some of the other cultural things, other cultural mores that prevent or that cause minorities in particular to have such trouble with good, healthy habits?
Well, certainly we tend to eat the way our parents ate, and they ate the way. So it's really about how we have done things over the years. We don't exercise. A lot of our exercise has been, we've received African Americans and other low and social economic groups. A majority of their exercise has happened in the course of their work. They have not used exercise as something they do in their free time. And so what we have, and so it's basically those two things that really eating the way we've eaten for generations. So the education is critical, but the access is equally critical. We know that as we give people information, we need to make sure that they have access to the less expensive variety, so if we want them to eat more fruits and vegetables, we have to make sure that they have access to fruits and vegetables that are comparable to what they're paying for other things. So it's those things. So how do you do that? You may not be able to, there is no corner store. Usually there is only a corner store. There is the markets that may have the lesser valued fruits and vegetables that just don't exist in these communities. And so we're talking about corner store conversions in some of the projects. So they're taking what currently exists and what people have access to, and a lot of people don't have the transportation that more affluent communities do. So we're making sure that what's available in communities becomes provides those healthier options for folks, whether it's raising their own gardens, growing their own food, whether it's bringing farmers markets to those communities, whether it's converting a corner store. We're trying to see more of that, because as we educate folks, then the excuse is, well, but we don't have it. We can't get it. So
I want to ask you, Amy, then let's talk about some of the nuts and bolts of how REACH in Norfolk is working. In other words, how are you engaging the community?
Sure. Well, our main focus in the Healthy REACH Norfolk project is really to make the healthy choice the easy choice. It's the idea of making the healthy choice the default behavior. And we're doing that by working on two different levels. One is at the city level. So we're working with the city to move forward a project to develop a master bike and pedestrian plan for the city, which will serve in a great extent as the city's what's called Complete Streets policy. And a Complete Streets focus is basically the idea that when you build a street, you don't just build it for cars, but you need to build it for people and bicycles and other modes of transportation. And we can't forget that when we build streets. And a street won't be complete unless we do.
Can you retrofit streets?
Sometimes it depends. Norfolk is built out, but there's a lot that we can do. And then also, looking at when we do dig up an intersection to replace a pipe, how do we relay that back down? So there's lots of different ways to do that, and there's lots of actually other opportunities related to funding for the city for that. So we'll be doing that. The challenge is that often when cities develop these policies, they develop them without the voice of the minority community. And that's really where REACH comes in. So part of what we're doing is doing a series of community dialogues all over the city with churches and civic leagues and other groups to talk with them about biking, walking, and healthy eating in the city, and then using that information to help inform and guide the priorities of the new master bike and pedestrian plan so that it does not forget those minority communities within town. So, for the partners that are working with us, we've already done a whole lot of community dialogues. About 200 people have participated, and we're going to be doing some more. And so that's a big piece of it. The next piece is working with organizations. So primarily churches, but also a few other organizations like NRHA and some others like that we're working with the Redevelopment Housing Authority to help them to develop policies and change environments. And we could educate you And that certainly there's a need for that in communities, and there's a place for it. But what our REACH grant is really aiming to do is to make those things possible, so that if I were to educate Terrance on how to eat well or how to be more active, that his environment supports it. So working with churches on healthy meeting policy and looking at what they're providing in terms of food. We also are partnering with Norfolk State. We have students that are working with us to do nutritional analysis in churches and other places.
So in other words, are you saying no more fried chicken at the church dinner?
No, we're not. But we're saying let's take a look at what you're offering and make sure at the very least you let people know what they're eating. And even better, that they have options. And honestly, even better is that they have only healthy options to make. But if you're going to have the fried chicken, let's do it in moderation, and let's make sure that there's an alternative for people who have diabetes or heart disease that want to make a better choice.
So, Dr. Newby, I know you're very active in your church. Do you think that this is something that would resonate with parishioners?
Interesting story. I probably don't want to get in trouble for saying this, but we were laughing. My wife and I were laughing the other night because this health fair we're doing soon. They came up with one of the associate pastors sent me a text message during a meeting they had because the issue of fried chicken came up because they were going to have food there. So she actually had to almost get into, I won't say a fight, but a little discussion because she said we can't have that there, and everybody was really
at a health fair.
Yeah, at a health fair, and everybody was debating the
fallacy.
point. Yeah, we're debating the point. Oh, there's nothing wrong with this. And again, it goes back to that cultural background is how you view the world, and a lot of people view, and I'm not gonna lie, fried chicken tastes good. I mean, let's not sit there and mince words. It tastes good. The problem comes in is what it's actually doing. And people don't know when you talk about moderation. People don't understand that word. I mean, it's all or nothing. It's really hard to and try to put a couple pieces out and see what happens. This is it. You go into that scenario. So I mean, it's really you almost. It's like you have to break the culture. And that is not easy to do. I mean, it's just like smokers that have an addiction to cigarettes. People have an addiction to eating a certain way, and it's hard to break that cycle. I mean, it can be done, but it's not easy. And it's almost like when you talk about those things where if you save one kid, that's worth it. If you talk to 2,000 that are in jail, if you convert one, it's worth it, and that is true in any situation. It's just you got to be patient with it because people are going to be people. If they're used to doing a certain way, it's just going to be tough for them to break it. They can do it, but it's just going to be tough.
Terrance, are you working with these community groups in terms of talking with them about the changes that you're trying to make within the community?
Yeah, in some instances, the health department, which knows that I have a real passion for health disparities, they allow me some autonomy when it comes to reaching out to communities. And a couple of years ago, I created the Illuminating Good Health Coalition, which consists of some 20 health and human service agencies throughout the region. And we do an annual event, and Dr. Newby spoke at our first event. And so it gives me an opportunity to bring together a bunch of different agencies. We provide free screenings, we provide free health education, we provide free food, no fried chicken, provide entertainment, and it's an increasingly popular event. So that does provide us with an opportunity to really reach out to folks. I wanted to add that just last year I was invited by NIH to moderate a seminar, men's disparities, complex conundrum. And there, I've always worked in the African American community, but there were speakers there that addressed the LGBT community and the Hispanic community. And when you look at the demographics in Norfolk and Hampton Roads and the increasing Hispanic population, I think that we need to broaden our reach because typically, most often in the area, we're focusing on African American men and women. But I think we really truly need to broaden our reach because that opened my eyes for me. So I think that with the Illuminating Good Health Coalition, we're probably going to reach much beyond just the African American community.
But I understand, Amy, that because of this grant, that it does specifically address the African American community because it is the largest minority within our area. And that is one of the things, if I'm not mistaken, Joyce, that is important is that whatever group is in your area, that's where you're
Exactly.
guiding
We
your
want to
information,
look at the groups
right?
in your given area that have the greatest disparity, and some groups, like when we've done, this is the second iteration of the program that we at UCLA have worked on, and when we were actually doing the work at the community level, we worked in all three communities because that community is so diverse, and there are such glaring disparities across all three communities, and so but generally we ask people to look and see what population in their given community has the greatest disparity and work within that group.
So, Amy, how do we keep the minority community then from saying, here we go again, here's somebody else that's coming into our community telling us we're doing it wrong? How are you reaching them at that level that they understand that this is designed for them to make decisions about how they want to live?
Well, part of it is the process that we use. We start out by doing an assessment that's really a dialogue with them about, well, what are you doing? Where are the opportunities potentially for change? And then ultimately they decide what it is that they want to work on among the things. And part of our role is to provide the technical assistance to tell them what is best practice. And then they have to decide for themselves, what can we work on? Where are we on this issue? And how far do we want to go? And as Dr. Newby said, social change and social norms is really the big piece of this, and it's tough. And so part of our process is to create a sustainable way of implementing change in communities. So I could come in and do an exercise program for children for a couple weeks, and that's great. Maybe they do well for a couple weeks. Or I could teach a church how to not only make change to start, but how to continue to make change to their policies and systems, which affect everybody. So getting people to reroute to the stairwell in a church, to incorporate exercise and physical activity into services and worship and meetings, looking at how we're feeding people during meetings and other types of events. And when we change the way that we do business, we change the way that our health is shaped. And that's really what this project is all about. It's about coming in and providing them some support to make the changes on their own.
If you're just joining us, we're talking about the REACH project in Norfolk with Joyce Jones Guinyard at UCLA's Fielding School of Public Health, Terrance Afer-Anderson with Norfolk Department of Public Health, Amy Paulson with EVMS, and my co-host, Cardiologist Dr. Keith Newby. So one of the things that I know, particularly in the public housing communities, and I am one of the commissioners for NRHA, that bicycle riding is very prevalent because it is the mode of transportation. So you were talking about these the bike paths and so forth. Are you incorporating that lifestyle into those decisions?
Absolutely, and the Redevelopment Housing Authority is a big partner with us on this project, and we've done some community dialogues with their tenant management groups, and we have some plan with their residents as well. And one of the things that we've learned is that there are some facilities, what we call bike facilities in Norfolk, so you might see those bicycles that are stamped in the middle of the road. Most people don't know what those are. From all communities, they don't know what those are. Those are actually called sharrows, and it basically means you share the road with bicycles here. And then we have what we call bike lanes proper, and that's where you see the stripe and it says bike lane, and it's got the bike in the little lane on the side. The challenge is that for people who are not avid bicyclists, sometimes they don't know how to use those facilities correctly, or they don't feel safe or confident doing it. So they ride on the sidewalk, or they ride backwards. We actually had one person in one of our dialogues to tell us, well, she goes, those bicyclists, they just don't know how to ride traffic. She goes, I had one, and he was riding the same direction as traffic right beside me in the road. And I told her, I said, well, that's actually, they're not supposed to ride towards you. You walk. That's how you walk. That's not how you ride. And so we have a lot of education that needs to be done, both for people who ride bikes to do it safely, as well as for people who are driving to be able to drive safely around bicyclists. And then, the bigger issue, I think, for a lot of our community is maybe thinking about multimodal paths that pull people off the road for people who aren't confident enough to drive safely with a bicycle on the actual roadway itself.
So, Terrance, this is not an issue that is unique to Norfolk.
No, not at all.
And so how can we spread the word then so that it goes across all of our areas
throughout
Hampton Roads?
I think a good way is the type of events we were speaking of earlier, health fairs that are regional events. I think there's a fair amount of education that can be accomplished, can be achieved through the media, if the media is effectively used. And basically grassroots initiatives that reach out throughout the entire community. That's word of mouth, and when you're doing any type of event, word of mouth really is the most successful It always proves the most successful tool. So when you do grassroots outreach, I think that's the best way to get the message out.
So what's the biggest barrier that you're hearing from the communities? And that can go out to any of you. I'll start with you, Amy. As you're talking to people in the community about changing their lifestyles and so forth, what's the biggest barrier?
Well, I think in particular for our low-income minority community, crime is a big piece of it. So, where they want to get out and walk or bike places, they're sometimes afraid because of crime. I think when we look at walking and biking traffic, is certainly an issue. When we look at biking, being able to afford a bike is an issue. But also just the historical knowledge of how to ride safely as well. And we start looking at things like food, it gets much more complicated. So you start looking at family life and working patterns as well as where you live. If you live in a food desert, what's available to you. And for somebody who's not been in not a full service grocery store, I would challenge you to go into a corner store and find dinner for your family if you don't have transportation. And
I remember a story once because it really drove it home for me when a young lady was describing how she had 3 kids and she had to get on a bus and she had to go to the grocery store. Then you have to carry the bags and 3 kids and get back on the. I mean, it just really became very, very clear the challenges that you have to go through and how we need to change that. Is that what you see also on the West Coast?
We see that across the nation. It's just not on the West Coast. And so that's why we are doing a lot of work to bring things where people are and to improve the access to these healthier options where people are instead of expecting them to go outside of their community. We also, see that people, when they have knowledge, and sometimes we make assumptions that people need a little more education, we find out they really understand, but they don't know how to execute some of these things. How to cook healthier foods. And so we've also done a series of the first thing we always have learned that we have to do is start where people are. And so sometimes by doing cooking demonstrations or sampling, letting people taste things, letting people see the things that they're not familiar with actually taste good and can be prepared in a healthy way is critical as well. So it's not just the verbal education, but it's really this broader education that people need. And start with small increments. Don't expect people to change overnight.
Yeah, because that's a big thing.
Exactly. We can't go from 0 to 100, overnight. Start, just making healthier options available first, maybe, and then doing things in small increments, and that tends to be very, very effective.
So, Dr. Newby, when you are talking with your patients and they are saying, I'm not really doing that bad. I'm really eating those healthy foods, but you can tell from a medical perspective that that's not happening.
Yeah.
Is it just constant education?
Yeah, I mean,
and you're beating them over the head.
Yeah, well, you have to in a way. I mean, there's one thing I've learned in medicine is when you talk about healthcare disparities, part of it is a trust factor. They have to trust their provider. You come into a community because you made a very interesting comment earlier about, say, here's somebody else telling us what to do, how to live, what we're doing wrong. That is true to a large degree, that people look at you with suspicion when you come into, an environment. You almost have to have champions within that community who people know, who you can help train, who will be that advocate for you going out there trying to, get people to change. Because if you just go in there yourself, I mean, for some people it may work, but a lot of people it won't, because they're just going to look at you suspicious and say, well, this person's just trying to tell me what to do, and I'm going to keep doing what I want to do regardless. And I mean, I hear it all the time, and it could be extremely frustrating, even for me. And when you look at, people are having a fit about this new healthcare law, they have a fit about insurance companies, and when you look at it, and every day I see totally preventable situations that occur because people just want to do what they want to do. They don't, you tell them, say, take this medicine. I need you to take it. Your blood pressure is 200 over 140. If you don't take it, this is what's going to happen. They tell you, they're going to do what they want to do. And the next thing they have this massive stroke, head bleed. They're in the hospital for a month with either very limited insurance, no insurance, or they have the insurance carrier is going to have a fit because then they're stuck in there for a month. And then that's going to, the astronomical cost of all that, only because you wanted to do what you wanted to do. but then when something goes wrong, you expect the world to take care of you. We run into that more than you'll ever want to know. And it can be extremely frustrating because you see you could prevent it. Oh, yeah, listen, I'm trying to help you. And some people you can, some you can't. But the key thing is the trust factor, because if they trust you, they'll listen to you.
It'll make it a little bit easier.
Yeah.
Amy, is that what we're doing here in Norfolk, training those community champions?
Absolutely, and I totally agree with the idea of working with champions. And actually yesterday we were with Joyce, who's visiting us, our grant here from UCLA from the program office, and taking her to some of our partners. And it's the champions within those institutions that will make the change. My role and the role of all of our REACH staff is not to come in and tell anybody what to do. Our role is to help them understand what are the best practices and help them figure out what might fit for their own institution. And then they make those decisions, and then they take the resources that we provide to them and make the changes. And I actually think we might have actually met with your church recently, and I think I heard that story yesterday. But either that or it was a very similar story where it was an associate pastor told me, she goes, we were planning a health fair, and she goes, they said they wanted the fried chicken, and she as a champion stood up for that. And part of it is making those environmental changes. So we talk about a lot about people making good choices. So if you've got somebody that's very involved in the faith community, which many of our minority community members are very involved in their faith communities, they may eat there 2-3 times a week sometimes, definitely several times a month. And so not only do I think churches and other community organizations like them have a responsibility to really think about what positions they're putting people in when they don't provide at least choices, preferably healthy choices. So if you only offer healthy things, people can only make healthy choices. But if you want to offer the unhealthy things, you at least must offer something healthy also, at the very minimum. So they have some responsibility in all this. And when we talk about, taking care of people from a spiritual standpoint, we also have to think about the whole person. And we want people in our churches, and we want them tithing, and we want them there as long as we can, right, in churches. So we definitely want to make sure that they're healthy. And so if I'm going to be in a church, we want them to start having those champions to stand up. And sometimes those fights are hard because you're friends with people and you don't want to upset people. You don't want to certainly have people stop coming to your Wednesday night Bible study because they don't like the food. But I think what we're trying to help them with, and what actually Norfolk State is being great partners with us and having the students available, is to help them to revise their menus and to find new recipes that people like just as much, but that are fewer calories, less fat, are basically a better choice. So,
because you don't have to go from fried chicken to carrot sticks.
No,
I mean, there is a medium.
Carrot sticks that are seasoned to taste like fried chicken.
But you do want to model behavior.
I like that. That was good.
So, what is, from a city's perspective, then, since you said this is a project that the city is working on from a policy perspective, what is going to be done about food deserts?
Well, we are not working specifically on food deserts as part of the REACH project, although that's certainly on our radar screen for healthy Norfolk.
Although that is a part of the whole nutrition thing too, isn't it though?
It is part of it. Yeah, definitely it is. Our specific project is working on helping community organizations to change environments and policies within those organizations. Okay. And then at the city level, we're working with the city on the bike pedestrian plan. Certainly food deserts is a big piece of the overall picture, and part of our community dialogues is trying to capture information from the public about that, so that hopefully we can bring more resources into Norfolk to start to work on those things as well. But with the city's perspective, the bike pedestrian master plan is absolutely key, because we have, and particularly our minority communities, so many people walking and biking. But we want more people, honestly, to walk and bike, and we want them to walk and bike not just because they have to, but for those who have a choice of walking and biking or riding in a car, to choose it. And we help them to make the healthier choice by making the healthy choice the easy choice. So in your neighborhood, if your church is 2 blocks down from your house, if it is harder for you to walk there, or scarier to walk there than it is to drive down the street 2 blocks, you're going to drive. If it is easier, if it is appealing and safe and comfortable, you may walk. And let's say you might walk there twice a week. So now maybe 10 minutes there, 10 minutes back. Now you're getting at least 40 extra minutes of physical activity. We're kind of re-engineering activity into your day. When we can make neighborhoods safer and get more kids walking to school, we don't have to worry about, okay, now we need an after-school program to run these kids up and down the street 5 days a week. They're getting 30 minutes of physical activity, 15 minutes to school, 15 minutes back. And of course, then we also need to look at nutrition, because that's a big component to health as well. But we can re-engineer activity. And so if every church does, we call it instant recess. For every meeting over an hour, and you know how churches, we love to meet in some churches, for every meeting over an hour or 2 hours, we're going to take a 10-minute intentional physical activity break. And we have some great DVDs that we've gotten in collaboration with UCLA called Instant Recess. And they're 10 minutes short, fairly easy. We're not talking Zumba, having to go take a shower. 10 minutes of just some activity, and they're fun. And we've actually done them as staff. And on the days that we get too busy, people are like, when are we going to do instant recess? And it's really fun. And you can also do things like take a meeting on a walk. So okay, we're going to stop. We're going to go on a short walk. We're going to solve wherever we are in the meeting. We're going to solve that question. We're going to come back, and everybody's going to report out. So not only do you get some activity, but now maybe Terrance is very quiet in the meeting and I'm not, and so but now Terrance has input because we're speaking out as a report out from the walk. There are all kinds of ways you can incorporate activity. So if you're very involved in your church there multiple times a week, you could easily get 10 to 30 minutes of physical activity, and then you take the stairs instead of the elevators. And what the research tells us is that if you put a little prompt that says take the stairs, people do it.
They'll actually do it.
So it's easy stuff, and what we can do is help educate the churches and the champions that are there about how to do some of these really kind of easy, sustainable things. And then we can provide some of the amenities for them. So if they want to do the stairwell promotion, we can help with the signage. If they want to do appropriate serving sizes and have a policy that says we're going to serve appropriate serving sizes. Maybe they're serving healthy food, but the portions are too big. We can buy them scoops, or if they need commercial grade apple slicers, so they can give the kids in the youth group fresh fruit. These are things we can help them with. And then we also help them with the policy piece or the guidelines, protocols, so that once we leave, they can continue to sustain the work into the foreseeable future.
Terrance, I think people might be a little surprised that crime is a health issue that comes under the health of the community as a whole. I think they may think of it as something separate. Can you address that a little bit?
I have personally experienced through my work at the health department the impact of crime as a public health issue, and that's because we talk about the disproportionate incidence of things that impact the African American community. I was running a fatherhood program for incarcerated populations, and when a father is not involved in the child's life, the child is at greater health risk. And because of the disproportionate incidence of African American men that are incarcerated, you see that is a clear indication of the impact of a father's absence on a child. Yeah, and in regards to a health risk. Yeah. It was a very insightful program for me. I started running it again. I'm anxious to get back into the jails.
To get back in there and to help them out. So what does success look like at the end of the day? After all these projects, and we keep throwing this money into these projects, what does success look like?
Success to me looks like a community change. It looks like a church that now is going about its business and serving its parishioners, but it's making those healthy choices available. It's making sure that if there is fried chicken, there's also baked chicken. It looks like a church that gives messages in their bulletins, and the pastor gives messages from the pulpit, so that people are, and it looks like schools that are giving these messages, so the children, when they come to school, from school to church, are hearing the same message repeatedly. It looks like a community that has access, and if we can't get the large supermarkets to come into those communities, there is a corner store where people have the access. So it looks like communities that have, in the Latino community, they call them promotores, and in the African American community, they're health promoters. But it looks like you have people who you do trust, people who you do know about you can go to to give you information, and so that if you cannot go to your physician regularly, or if you don't need to go to the physician all the time, you do have someone that you can go to. So it looks like many things in many communities, but it looks like people who, at the end of the day, in another 5, 10, 15 years, who are living life to the fullest. They're living past 40 and 50 years old. So to me, that's what it is. That's long term. We know those stats won't change overnight, but it does mean we're moving toward that.
And so then is the CDC at the point where it is willing to continue to fund these types of programs?
Yes, actually,
so that because they know that it's not short term.
Exactly. And that's been, we've gone back and forth with that. But there are a number of people at CDC who have done this work, who understand that this is nothing that's going to happen overnight. As a matter of fact, they just released yesterday the first of 6 FOAs or program announcements to continue this work. And the very first one is a continuation directly of this line of work. And so it's not being called REACH. There may be, I'm not sure what the next 5 will look like, but we do know that they have, particularly through the healthcare, the recent healthcare initiative, there is a prevention component, and there are dollars in there for prevention that really is slated to continue this work, and so we're thrilled to see that.
Amy, the Norfolk reached out to the churches in particular in terms of the community groups to help. What has been the pastors' reactions? And I mean, do you have all the churches signed up now, or
we don't? And we actually, this is only an 8-month project because of some things that happened at the federal level during the award process, but. We can't, with the current project, reach out to everybody. So we've selected some churches based on size and willingness to work with us. And there are some pastors that are really, really interested in moving this forward. And there's some that just really, we've gotten turned down by some churches that said, this just isn't for us right now, for a variety of reasons. It may be they've just got too much going on. They don't have the staffing. It could be that, right now, health is just not their thing. And what we're really trying to focus on is what we sort of call the low-hanging fruit. We want to work with you if you want to work with us. And certainly if you've got a church that they're just not interested in making any changes right now, well, the time will come when we'll work with you and hopefully with other resources be able to bring some support to you. But we're really interested in working with the groups that are poised for change. And, we've talked with so many churches that have actually started to do a few things, but weren't really sure how to grow it. How to, okay, now that we're, doing a few of these things, how do we take it to the next level? How do we make sure that, if, Barbara retires and moves to Hawaii, that all the good isn't going to go because she's not the person in charge of the cooking ministry anymore, or that kind of thing. And so it's creating sustainable change and making the healthy choice the easy choice in communities like churches.
And what do the champions, what is their reaction?
Sometimes they, it's a little bit of an eye-opener for them because our focus isn't so much on the individual, and there are lots of programs that do focus on the individual, lots of great programs out there for individual education. We're really focusing on the organizational level. And so when we come in and say, well, let's do a little assessment, see where you are, they automatically think that we want to know, how many people in our church have diabetes? Or, well, certainly that's great information to know, but what we're really interested in is that vending machine that you have right there. How are you competitively pricing the healthier options so that you incentivize people to buy them? What we're really interested in is how do you support or not support women who are breastfeeding in your church? How are you promoting people using the stairwell instead of the elevator? What about food? So those are the things that we're interested in. What is your organization look like? And so there's a tool we use from the CDC called the CDC CINCH tool, and it helps us to assess their environment and their policies that they may have, so that we can figure out how far they've moved over the course of the program.
So that's really an interesting way to approach it this time. I hadn't thought about like the vending machines and so forth. Dr. Newby, do you think that there are churches in our area then that can take the lead on this, and regardless of whether there's federal dollars to support the program, would naturally want to push it out and to make it bigger?
Oh, I think so. I mean, to be honest with you, I've been doing volunteer work for years. I never gotten reimbursed or paid for any of that, So, I mean, just personally, this is the right thing to do. It's always nice to have dollars to help support a program, but when it boils down to it, the brass taxes, people got to want to do it, and if they want to do it, they're going to do it regardless of whether or not there's incentive, there to do it. I think the dollars help in terms of the promotion of it all. And once you get, it could be like wildfire. Once you get it started, if people really are into it, they're going to do it regardless because they see benefit. The biggest issue is trying to show people benefit. That's kind of like that unseen reward that you can't always immediately tell. And see, then people will get frustrated because it's like you come in, you set it up, and they will do it. But once they don't see everybody's gone, it's just them. And then they don't see that benefit anymore because they don't see people. We all want that immediate gratification. If you're going to start losing weight, you lose 5 pounds, but it takes you 2 weeks to lose that extra 5. You're going to get frustrated and say, forget it. Because we are immediate gratification society. So I think that a lot of churches that want to take that lead role will do so, and they will stick it out regardless. But trying to get that champion is where, that's the hardest part. And then sustaining. She made a good point earlier about, trying to sustain it. That's where the problem comes in.
I was going to say, Amy, so what is the plan for sustaining REACH after the formal grant period is over?
Well, we're really appreciative, first of all, for the opportunity to be funded by REACH and through our program partners at UCLA and ultimately CDC, where the money originates, because this type of project is very human resources intensive. So, a lot of times we have churches poised, but they need a catalyst. They need somebody to help them with the technical pieces to even understand that, hey, maybe instead of trying to provide an exercise program for 20 people on every Tuesday, maybe we should just change what we're feeding people, and that would have a bigger impact. So that's kind of where we come in. And from a sustainability standpoint, everything that we're trying to help them do, they should be able to sustain. So if they write a policy about what they're feeding people or what their recipes are or anything like that, we're having them to try to include a clause about how often they're going to revisit it to make sure they're still doing it. Okay. And then sometimes environmental changes live on. So, once I put a bike rack out in front of your church, people can continue to use it, and it encourages people to bike to church. So
if someone wants to get involved, if they want to help, who should they contact?
They can contact us. EVMS is the agency that received the REACH grant on the behalf of Healthy Norfolk. So we're the ones administering it. They can contact us at CINCH, CINCH, at evms.edu. And that's our Consortium for Infant and Child Health program, which is where this grant is being organized out of in our Department of Pediatrics. Or they can call us at 757-668-6426.
Okay. Thank you all so much for joining us to talk about REACH and about this program. And, the main key is for everybody, as you said, Joyce, to just take a little bit at a time. Take one thing and maybe focus on that and then move down the line. Mm-hmm. And so, again, give that phone number one more time for me, Amy.
Sure. It's 757-668-6426.
Okay. And we will be right back.
Hello, I'm Reverend Al Sharpton, host of Politics Nation, and you're listening to Another View on WHRV 89.5 FM.
And that's Reverend Al Sharpton. I tell you what, that's pretty cool. A Hampton Roads native has become an internet sensation with his unique way of summing up classic literature. The show is called Thug Notes, but unlike the Cliff Notes you might pick up at your favorite bookstore, Thug Notes is on video. Our Lisa Godley recently sat down with the host of this popular segment, Hampton native Gregory Edwards.
What it do, blood? Welcome to Thug Notes, your main hookup for classical literature summary and analysis.
Hosted by Gregory Edwards, alias Sparky Sweets, Ph.D., Thug Notes looks at some of our favorite books in a whole new light. For example, this clip from The Scarlet Letter.
Even the scrappiest hoods know that Hester's A standing for adultery. But listen good, blood, because that ain't all it means.
Edwards, a native of Hampton, Virginia, uses his comedic skills to break things down, and the response has been amazing.
we didn't think it would hit this hard, and it really has been really good.
Okay, tell me a little bit about it hitting hard. Tell me a little bit about where you're reaching, who you're reaching.
Well, we have about 200,000 subscribers. We've been mentioned in Huffington Post almost every week. We had a big article in the New York Times, which really just got us a lot of attention. Tavis Smiley saw the New York Times thing. His producer got in contact with me and Jared and Jacob, and I did the Tavis Smiley show. It's been really successful.
Edwards says the idea was the brainchild of Jared Bauer, who along with Jacob Solomon created Napkin Note Productions, the company that produces Thug Notes. He says Bauer got the idea while watching a theatrical performance and thought, why not break this dialogue down into street vernacular?
Break them down so I don't want to say regular people, but for people can understand it. We're breaking down in layman's terms, not using, well, sometimes the words are big, but we do it in street slang. And I don't want to say black slang because everybody uses these words nowadays. It's not just us. And we just break it down and make it easier for young people to get it.
This week on Thug Notes, we going ham with Animal Farm by George Orwell. Majors say that men are the only creature on the farm that consume everything but don't produce nothing, which means the only thing standing between the animals and righteous living is stepping to and stomping their two-legged oppressors. Rebellion, dog.
Edwards says the idea is not to use the program like Cliff Notes as a way to avoid reading the book, but to hopefully spark interest in classical literature that wasn't there.
Hopefully they'll watch the video and think to themselves, I didn't think about it like that, and go back and read the book differently and just get kids, not even kids, but everybody excited about this old literature, and get them back on track.
Thug Notes hit the World Wide Web about 10 months ago, each clip about 4 minutes in length. The goal is to get it to kids, but because of the way the message is delivered, that may be a bit of a challenge.
It's funny, it's educational, it's a little, we swear and use words that maybe wouldn't be good on radio. But it's a hard angle to figure out how to promote this and put this. So what we're doing right now is we're asking, we have a big fan base, and a lot of it is teachers in America, teachers overseas. People really love what we're doing. So we're asking them to show it in the classroom if they can, and if it's a problem, put permission slips out, let people sign away. And we're trying to get more of a response from teachers and students to see what we can change, what we can fix up.
Edwards says the goal of Napkin Note Productions is to shake up education. In fact, their next project is a look at art history and classical music in a different light.
Comics have been teaching through entertainment for years. And, I've had some teachers in my life that have made education and made their teaching more funny so that we can understand it more.
Listen up, comrade. This book ain't just a story about animals. On the real, Orwell dropping some mad allegory about the rise and fall of the Soviet Union.
For Another View, I'm Lisa Godley.
Quite a different way to look at the classics, I tell you. And that's our show for today. I'm so glad you decided to join us. And remember, you can take the information you heard today to your civic league, church, social organization, or anywhere else you know to get people involved and excited about changing our eating and lifestyle habits for the better. Next week, we celebrate the birthday of our country, so there will be a special 4th of July programming. And I'm going on vacation, so I'll see you on the radio on the 18th of July. In the meantime, producer Lisa Godley sits in the interview chair, and we'll have more great conversation for you on Another View. So be sure to tune in and show Lisa some love. Our theme music was composed and performed by Jay Sennett. Lisa Godley is our producer. Victor Bowen is our audio engineer. I'm Barbara Ham Lee. Thanks for listening, everyone. I really appreciate you being here, and let's get together again next Friday at noon for Another View.